Slide. So a pause for our learning objectives. Today, we really want to take apart the ethical and pragmatic challenges to collecting race, ethnicity, and language data, and really altogether chart a course for advancing equity. So today, we are hoping that we can recognize current work going on in our state on utilizing REL data, analyze ethical and pragmatic challenges to collecting and storing data, identify opportunities for alignment and standardization, describe how data can be used to inform actions to advance equity, name one current practice example to advance health equity, and identify one action that we all can take to utilize REL data to advance health equity. We all come from different places and different backgrounds, but we all can collectively move forward. Next slide. So today we also really seek to build off of our CDC's definition of health equity, where every person has an opportunity to attain their full health potential, where no one is disadvantaged from this because of their social position or other socially determined circumstances. I think we're lucky in Washington State to be able to work with the Foundation for Healthcare Quality, the Washington Health Alliance, and Comagine Health, that we are all mission-driven organizations that have really worked to make equity a core part of that mission. And our vision at the foundation really is that everyone in our region lives a long and healthy life. And so our mission here is to catalyze the system-wide improvement by involving everybody who intersects with our healthcare system in various ways within a framework driven by data, consensus building, feedback, evidence-informed best practice, and expert opinion. Our foundation has been part of our Washington State health ecosystem since the late 80s, really serving as a home for healthcare improvement collaboratively. Our care outcomes assessment programs work with member health delivery systems to improve cardiac care, surgical care, obstetric care, and spine surgery. And we are also home to the Public-Private BRIE Collaborative, created by our state legislature to set community standards of care through multi-sector action, as well as the Patient Safety Coalition and Smooth Transitions. Next slide. And I want to take a moment to welcome Dr. Emily Transu, newly Chief Clinical Officer with Comagine Health, and I'm grateful that we get to continue to work together. And now I'm going to turn this over to Dr. Drew Oliveira, Executive Director of the Washington Health Alliance, to say a few words.
Thanks, Ginny. I think this is a really important topic, and it's great to dive into it a little bit more. As you know, the Alliance has been reporting publicly on data related to quality for a number of years. And this past year, we started looking a little deeper into the cost of care. And then most recently, what happens to care depending on where you live. And we applied what's called the Area Deprivation Index to all of our filters so that we can start teasing out a little bit more where we need to look and what specific areas are going to be important. And what we found, especially in the commercially insured population, is that where you live matters a lot in terms of preventive services, some of the quality measures. And in addition, cost of care and your risk of your population health risk also increase as you move from a more privileged area to one that is less. All of that basically tells us that we need to dive into each of those communities, understand a little bit more about what is really happening within those communities, and having another filter in terms of the culture of that community, any language issues that might be there, any other systemic issues that we may need to look at will help us in terms of what interventions matter for that community and what interventions are going to be successful, and then be able to measure the progress of those. So that's sort of the direction that we're interested in moving. I'm delighted to be a part of this, and looking forward to the panelist discussion and some of the comments from those in the audience. With that, I'm going to pass it over to Emily.
Thanks so much, Drew and Ginny. It is very exciting to be here. I'm Emily Transu. I am the Chief Clinical Officer at Comagine Health. I'm learning to have that roll off my tongue more easily as I've been here a few months. For me, really thinking about data and health equity, I would call out an arc that splits a couple of my past and present roles. Comagine Health is the Medicaid external quality review organization for Washington, and part of what we do in that is a really extensive data analysis of Medicaid quality, breaking down that data by race, ethnicity, and language, as well as other categories to identify disparities. And then I think for all of us, there's that question of, okay, data is one thing, what do we do with it? When I worked at a Medicaid MCO, we identified at one point in our data that we had disproportionately really low rates of mammography in Black women in a specific urban area. And I think we all know that there are higher death rates associated with that as well. So we went out, after recognizing that in the data, we went out, worked with community leaders and churches and created a special screening event focused on this population. We brought in food, and we had childcare and transportation to really lower barriers and make this a very positive experience. And what we saw from that was a huge improvement in screening rates, interestingly, not just in mammography, but in some other conditions also in that population. So there's some really exciting stuff that comes out of this, and also just profound challenges. To quote Sarah Halvick and her team from Comagine, we'll hear from her later, but the idea that the concepts of health equity and how to do it well can often be in direct conflict with the concepts and principles of data analysis and how we normally manage data, whether that's throwing out outliers, focusing on the data we have instead of what we need, thinking about results versus process. So I think there's just so much excitement and also so much challenge in this space. And I'm really, really happy to be here today for all of us to talk about it.
Thanks, Emily. I'm happy you brought up a couple of those themes are going to come through in the presentations we have from our speakers today. For everybody on the call, my name is Emily Robson, and I use she, her pronouns, and I'm the Transformation and Community Partnership Manager at the Foundation for Healthcare Quality. I just want to review quickly what our agenda is today, and then we'll jump into the presentations from our speakers. So we've already made it through our introduction, and then next we will have a presentation from 4 different speakers today. We're so grateful and honored to have them join us. We have Dr. Rose James from the Public Health Public Health Associate Officer at the United Indian Health Institute. We have Jessica Beach from Molina Healthcare, Cade Walker from the HCA, and Dr. Matt Jaffy from the University of Washington. After each presentation, each speaker, we will hold a mini Q&A. So if you have any questions specific to the material that speaker presented, please place it in the Q&A box and we'll have an opportunity to ask them those questions. And then later near the end of the webinar, we will open it up to a large group discussion with all of our speakers today and have some prompts for them. But also, if you have some larger questions that you want them to answer, please place those also in that Q&A box. We'll go ahead and review them then. So now I'll pass it over to Dr. James.
Hello, thank you, Emily. And it's a pleasure to be here today. My name is Rose James, and I also have an Indian name passed down by my great grandmother, Tsitsiabach, and I am the Public Health Associate Officer with the Urban Indian Health Institute, not United Indian Health Institute. And I'm going to talk a little bit today about reclaiming the narrative that comes through our stories in the form of data. Next, please. The Urban Indian Health Institute is one of 12 tribal epidemiology centers. We serve over 60 urban American Indian and Alaska Native organizations across the country. And we support that network, including health programs and social and health service organizations. Next, please. We're also a division of the Seattle Indian Health Board. We're the public health arm of the Seattle Indian Health Board. UIHI serves to improve health of American Indians, Alaska Natives by identifying and understanding disparities as well as resiliencies and strengths, and strengthening capacity in public health and infrastructure performing disease surveillance and disease prevention, and developing health promotion and disease prevention activities that are grounded in our Indigenous methodologies. Next, please. This is just an activity we did with a group once when we did a presentation. What comes to mind when you think of Indigenous evaluation? And really the most prevalent responses included culture, storytelling, and community. Much more than just what comes to a lot of people's minds thinking about data as statistics and numbers in populations. It's more than that. Data is part of our stories as Indigenous people. Next, please. And at the Urban Indian Health Institute, we take our approaches very seriously. The use of data, whether it be through research or evaluation, has done much harm in Indian communities. These are just a couple of examples that are from more recent times. How we approach the communities and engage the communities in that data collection, use, and reporting is really an important part of the approach. Next, please. Data can be shared in many different ways as well. It's not just for the statisticians or the public health professionals to understand. It's for those people who are running the programs to take that information on health indicators, on the needs of for different kinds of services, for example, of their population that they're serving in their communities. So we approach our reporting in many different ways, including through art. Next, please. I'm going to give you a quick example of ways that we have been working with other agencies and groups that have traditionally had a deficit approach to collecting data on our population and really not capturing American Indians and Alaska Natives to the degree that we should be, so that our population does count. The Healthy Youth Survey in Washington State includes a broad range of topics. Many of them are here: sexual behavior, violence, disability, family risk and protection, nutrition and exercise, for example. Over the years, we've worked with the Healthy Youth Survey team at the DOH to address and shift how they were looking at our population in the middle to high school level. Next, please. And collecting that data. So some of the ways that we did this was really, how are you even capturing race and ethnicity? And prior to the 2019, I'd say, the Healthy Youth Survey was collected, race was collected in American Indian or Alaska Native only, versus somebody like myself who's a mixed race person. I'm Latina and white and a Lummi tribal member as well. I would go into that category of other or multi-race, which overshadows, as you can imagine, the population that we're actually trying to capture this important information about. Some of the things that they found, though, after working with how they were capturing that race and ethnicity, was that American Indian and Alaska Native youth in the 10th grade were just as likely as their peers to be hopeful and have somebody to talk to. They were part of communities that supported them. So some of the resilience factors came out when we started capturing more of our Native youth. Next, please. Also more likely than their peers to report use of substances like alcohol or cannabis. in the last 30 days. But even with these challenges, Native youth experienced reductions in substance use overall between 2018 and 2021. Next, please. In prior years, reports focused on presenting data for youth in mutually exclusive categories, as I mentioned, just American Indian, Alaska Native alone. But based on our best practices and guidance from the American Indian Health Commission, Northwest Portland Area Indian Health Board, they decided to change how race and ethnicity data was presented, and now do it in categories of alone or in combination with other races. Next, please. I'm going to wrap this up. Can you go to the next one? Because I know I'm almost out of time. So the approach to collecting data, to analyzing data, interpreting it, and reporting it involves the community at the center of it. The community that knows what that data means and can tell that story. So we have an evaluation framework, for example, that we apply to many of our data collection plans. And it involves the community at the center. It looks at resilience and strength-based health indicators and rigorous data that's collected and used with the intent to benefit Native communities and to put that data into action. Okay, I think I'll end there because I know I'm out of time and I want to save some time for questions, but I hope that gave you kind of a taste of what we mean by Indigenous data collection and decolonizing data, which in the language of this particular session, it goes a long ways to equity and addressing health disparities. If you can actually make visible those populations that are traditionally overlooked or underreported. Thank you.
Thank you, Dr. James. I think that's an important topic to bring forward in this presentation, and especially how you were able to speak on that with your example of the Healthy Youth Survey, of showing how important it is to bring those populations to the forefront and making sure that we're capturing them authentically and correctly to understand the full extent of the health strengths and concerns that they may have facing those different populations. As we wait for some questions to come in, I was hopeful that you might be able to speak a little more to this framework and specifically how you may utilize it on another example or how it was developed within Urban Indian Health Institute.
Speaking to the latter question, we actually years ago, the director, myself, and some of the other leadership here at the Urban Indian Health Institute and Seattle Indian Health Board recognized that the frameworks that were already available for doing evaluation, data planning, and collection for, say, health programs, diabetes programs, et cetera, were available around Indigenous people tended to focus on federally recognized tribes and sovereignty, which is a really important focus. Absolutely. However, over 70% of Indigenous Native people live outside of those federally recognized tribal lands and are not necessarily covered by those sovereignty elements. And so we decided that what does speak to our Indigenous values for data and evaluation in the communities that we're working with and serve, that are, we call them urban Indians, but they're literally people that just have always lived on these lands and often became urban areas around them, like here at the Duwamish lands.
Thank you. We do have one question that came in. It touches maybe a little on this, and it's a big question. And so I'm hoping you may have some guidance if you feel comfortable answering. Is what recommendations would you give to acknowledge and respect differences between and among tribes? And I think also we can include urban Indians within that as well.
To acknowledge the differences between and among tribes?
The question said to acknowledge and respect the differences between and among tribes.
Mm-hmm. I think, first, if you are working with a particular tribe or community, if you're involved in doing research or data collection or data planning of any kind, or trying to access data for particular reasons, like looking at health disparities and services, that you should really learn more about the community that you're serving first, because you're right, tribes are very different even within the same region. Take Duwamish and Lummi. Lummi is actually my tribe. The reservation is located in Bellingham, Washington. And our relatives actually live on both sides of the Canadian border. So understanding that the language and the cultures may have similarities even within the same region, but may also have their distinct cultural practices is really important. And histories with research, as well as histories with the federal agencies, state agencies, etc. So acknowledging it is just important. I think one of the approaches that I always appreciate is if somebody is not familiar with our communities, is not as immersed or has not really worked with our populations before, that they acknowledge that and they become a learner. And so it is a different approach than we've seen in the past, where you're coming in as the expert, the data expert, when you may not have really considered some things that are really important to the story you need to tell with the data as data, including things that people make, things that people practice, that may not have fallen into your categories that you've already predetermined. So become a learner.
Thank you. I think that's something we can all take back with us, and also that practice of humility as well, as we are learners. We want to thank you for your time, Dr. James, and we'll move forward with our next speaker. Bear with me, everyone. We're just going to go through these slides a little quickly from Dr. James. And I will bring our next speaker up, Cade Walker from the HCA.
All right, well, good afternoon. It's a pleasure to be here with you. My name is Cade Walker. I'm with the Healthcare Authority. More specifically, I'm with the PEB and SEPR, the Public Employee and School Employee Benefits Board programs. So while a lot of you may have interactions with the Healthcare Authority specific to the Medicaid side of our house, which is very much the larger side of things, I work on the commercial side, working with the employees, and really the employers in the state of Washington in the K-12 higher education and all of our agencies, as well as all the other entities, public entities that contract with the PEB program to get benefits for their employees, like cities and municipalities, all of which comprise our approximate 700,000 employees and their dependents in the state of Washington, as well as retirees. And so in that regard, next slide, please. What we do in the agency regarding race, ethnicity, and language data collection, we have our Apple Health, our Medicaid program, and our Department of Behavioral Health and Recovery. They collect a lot of data. They already have certain race, ethnicity, language data types and sets that they're required to collect as part of federal requirements and other state requirements. So they have had a lot longer runway on data collection with regards to these sorts of data sets related to race, ethnicity, and language. And then they use it for all the purposes related to those same requirements. But I think the more specific part that I was asked to come talk about today is encompassed on the next slide, which is on our public side and the employee side, when we kind of put on the hat in the agency as an employer, as opposed to the Medicaid state purchasing entity. The PEB and SEB programs, the PEB program has been around in its current iteration since the 80s, and the School Employee Benefits Board program is a recent creation, which had its first plan year in 2020 after legislation in 2017 mandated the consolidation of all the benefit purchasing for every public school district in the state. So in 2020, all 295 school districts began coverage for all of their employees with the newly established School Employee Benefits Board program, which is very similar structure to PEB. Just runs on the school and for the school employees and the educational service districts of K-12. 2 years ago, or 2 summers ago, in a collective bargaining session, we conduct collective bargaining sessions with both on the Public Employee Benefits Board side, as well as with a coalition of represented labor groups on the SEB side, and we negotiate certain aspects of the benefits every year. 2 years ago, let me check, it might have actually been 3 years ago now, in some of the aftermath of the George Floyd murder, the bargaining group had a component of it, a memorandum of understanding that was agreed upon to create a work group to assess equity and to look at equity specific to health equity in the SEB program, and addressing issues related to race or ethnicity or economic status or language barriers in the program, and how we would look at that and what efforts we could take to resolve that. Contemporary to that, there was also a report from the Joint Legislative Audit and Report Committee from the legislature that was looking at similar issues or trying to assess certain aspects of the SEB program or K-12 in general. And what they ran into and what our work group ran into is that data was going to be one of the biggest hurdles for us to try and overcome in trying to answer some questions from the legislature regarding equity in the School Employee Benefits Board program. So the work group began trying to assess what current data streams might be accessible for us to obtain the necessary data for us to begin assessing health equity issues within our program. And one of the things that came up very quickly was a concern about the privacy of that information. And one of the barriers that existed was whether or not that information, once collected for the SEB program, would not be subject to public disclosure laws. Unlike most private employers, where their collected information is not going to be subject to disclosure under a public records request, being that we are the state of Washington, we are subject to those disclosure laws. And there wasn't any language that gave us assurance that if we were to collect that sensitive information from members, that it would not necessarily fall under HIPAA protection and therefore may be subject to disclosure. So there was a need to have legislation passed to protect that information from disclosure should an entity come and attempt to request that information from us. That was going to be a little bit of an effort. We were planning on something in that regard for the 2024, perhaps 2025 legislative session, but due to some fortunate circumstances regarding some CMS requirements for Medicare Advantage plans to collect that information from its enrollees, and that we are a sponsor of Medicare Advantage plans for our retired population, we had to begin that process of collecting race, ethnicity, language data for Medicare Advantage enrollees that we, for this plans that we sponsored. We had this opportunity to go to the legislature and say, well, because of this information we need to collect for CMS, it would make sense for us to just create a full exemption for us for both of the PEB and SEB programs to exclude from or exempt from disclosure laws all of the information that we collect for the enrollment processes for PEB and SEB. And we explicitly stated in there race, ethnicity, language data, and other data types that would be very helpful for us, or we imagine will be helpful for us when we get down the line to trying to analyze and look at health disparities, health equity issues in our programs. And so last session, we successfully had sponsored and passed Senate Bill 5421, which granted us that exemption from disclosure of all of the enrollment information we collect, making it sure for us as well as for the members who we're going to be asking for to provide us with this information, that information won't be disclosed. Which brings us pretty much to where we're at today. The legislation was passed. It goes into effect. I think it goes into effect in about 3 weeks from now. And so we will be able to have that assurance in place that that information is protected. And then we were able to then continue our journey in trying to, or in data collection of race, ethnicity, and language data. So it brings it to the what we're doing now. We're working currently on trying to establish where, how we're going to be collecting that data. Fortunately for us, we've been engaged in a multi-year process of creating a new online enrollment platform that we'll call Benefits 24/7, which launches, I think, in a week from tomorrow, or maybe something like that, rather soon, where we will have a new online platform that will be greatly enhanced from our current existing system. And it has a modular design, which will allow us to very easily add in fields in the demographic area or on its own specific page on the enrollment page to have members submit their race, ethnicity, language data. Now, the current thinking or current understanding is that we don't have a mandate for us to collect that. So any efforts from the members of submitting that information will be on a voluntary basis, which is going to be a hurdle. That is really hurdle number one at this point, is that, or hurdle now, is how do we message to our 700,000 members and dependents that we're going to be asking for them to provide us with that information, provide it for themselves, for their dependents, and help provide us with that information for the purpose of us being able to do a better job. But that does require us messaging that and getting out there and reaching out to all the different organizations and labor unions, and working with them to encourage them to help support a message of why it's important for us to do it. Because I think all of us in this meeting here today can appreciate why it's important for us to be trying to collect this information and to do good things with it, and to be able to provide better support to disenfranchised populations or to areas where we've historically been neglecting, not intentionally, of course, but by the nature of the systems and the lack of transparency of racial barriers that exist in our programs that we just haven't been able to see because we don't have that data. And so getting to that point where we're able to start collecting it, having the questions really ferreted out about what we want to use it for, how we're going to be storing it, are those big questions that we're currently facing in our journey. And so I think that's why we got to come here today to talk about that process, getting to hear just the barriers of us being able to ask for those questions. And then, of course, we do have our last components of it, which I'm really grateful to have an opportunity to work with our agency on. It's a lot of our equity work in general and focuses on health equity, working with Quinn Wynn and our Health Equity Office of Health Equity in implementing the governor's pro-equity and anti-racism order 2204, as well as helping support the 4 work streams, of which data is one of those key work streams of our our pro-equity anti-racism work, which we've got a lot of support on, a lot of activity. It's just a slow process getting there and making sure we don't trip up over ourselves, and we try and get it as right as we can the first time, rather than trying to have different iterations and then prove ourselves maybe not quite as confident with our members as possible. So with that, I'm happy to answer any questions you may have.
Thanks, Cade. As we wait for a question to come in, we'll kind of monitor the time as well. I have a question that I was thinking to myself, and then you started talking about it, which made me really excited. You're talking about how now that you're able to, you feel like securely capture this information from your audience members. How are you doing that messaging, or do you have an example of some tools that you're utilizing to share that information of why you're asking these questions?
No examples yet of how we're messaging it, because we were getting to that point. This is really fresh off the presses. We're waiting for the law to go into effect in just a couple of weeks. So this is very early, but what I'm imagining, what we've already started thinking about is, one, we want to hear from the members and work with them to say, okay, we're going to be asking you for a sensitive information. We want to go to our communities that we serve and work with our stakeholders, and more specifically with our communities, engage with them and say, okay, help us better understand what your concerns will be. Help us understand how you're going to view us doing this, because we're in this all day long. We're in this space all day long working on this, and we're going to be asking you to divulge information and provide us information that you may feel concerned about. Historically, might not have been real confident about providing that. You would view it as a possible barrier for many different things. But how do we as their employer help gain their trust and show the utility and the value of what we're going to be doing with that information, and then turn that into our messaging that we provide out once we've had that opportunity to engage with our community to talk with them about this and have them be really a guiding force for us.
Thank you so much. We are at time, so I'm going to move to our next speaker, but thank you, Cade. We'll bring you back in a little bit to speak with the entire group. Our next speaker is Jessica Beach from Molina.
Hi, everyone. Thank you for allowing me to present today. My name is Jessica Beach, and I'm the Health Equity and Cultural Competency Director at Molina, Washington. I'm really excited to be here today to talk about the complexities of data collection related to race, ethnicity, and language, and what that really means from a health plan perspective. So I'm just going to go ahead and jump right in. All right. So I'm going to start with an overview of just who we are and what we do as a payer in the Medicaid space. Then talk a little bit about why this data collection is important from a health plan perspective, and then talk about how we actually use the data that we collect. What is it that we're doing with it? And then what are the things that we consider, because there are so many complexities with this type of data. Like, what are the questions that we're asking ourselves? What are we thinking about as we're moving forward with this and being learners in this process as well? So thanks. Go to the next slide, please. Thank you. So just a quick slide about Molina Healthcare. We are a Medicaid plan in the state of Washington. We've been here for over 21 years. We're the largest Medicaid and marketplace plan in the state with over 1 million members. And so that's the perspective that we're coming from, is we're serving our Medicaid members. We're working actively with our provider partners, community partners, and HCA in our partnership with the state. And so those are the perspectives that we try to bring into how we talk about this data, how we think about the data, and what we do with it. Next slide. Thanks. All right. So just a couple of things about why REL data is important. I think first and foremost for me in my role around health equity is that this data gives us a picture of who our members are, where they're coming from, and it allows us to kind of better get to know who they are, where they're at, and start thinking about how we may engage our members, how we do the work we do for our members, who we partner with. So it's a piece of the overall puzzle, but it's a very important piece around how we get to know who our members are, what their needs may be. Also feel like this data helps us, again, I know we're talking really specifically about REL data today, but data in general, I think, is a really big picture, and this is a part of it. So I think that this data as well guides our decision-making and informs the actions that we take as a plan. It helps to shape our priorities and where we focus our work, and contributes to things like budgeting and other health plan decisions. And then also another just kind of practical reason why this data is important to us is that it's a really big component of our reporting out. So whether we're reporting to the state or an entity like NCQA for an accreditation, this data is a really critical part of that. All right, so I think this is always a really interesting topic to talk about around, like, where does our data come from? So we have 3 big buckets of where our data comes from. First and foremost, it's enrollment files. That's a file that gets sent to us from the state. REL data is one component of the overall enrollment file, and I like to think about this as a point in time snapshot of our members. It's self-reported data. It's usually driven by like a Medicaid application or an application for benefits, which is, I think, important as we get to the complexities and the considerations, because I think we have to, when we look at that data, there are oftentimes blanks or information that was not captured. And I really try to think about our members and their level of comfort in sharing that data with us, but really anyone. So if they're at a provider's office or filling out another benefit application somewhere, there has to be a level of trust to want to share certain things. And so I think that the hesitancy may contribute to some of the information that we don't have or the gaps that we don't have. But I think that's one piece that we really have to think about as we look at the data is the level of comfort our members may have in reporting data about themselves and where that data is going. The second piece I'd like to call out is like the internal data collection that we do, which could be the initial health risk assessment, which is a screening that we do for all of our members within their first several weeks that they're on the health plan. There's not a really high completion rate of that. So that's someone reaching out to the member directly, asking them a series of questions, which do include some of these REL data points, but also things around like social determinants of health and overall health. We can look at some of this through our claims, grievances, provider race, ethnicity, and language data to some extent. So I won't say we're directly collecting all of that. Some of it we're directly collecting, like the health risk assessment, and to a certain extent the providers, but sometimes we're applying that enrollment file to some of these other items like claims or grievances or utilization or something like that. And I'll talk a little bit more about that when we get to the complexities. And then the last piece is external data. I think it's always important to look at what we have internally along with external data sources, which could be state or community level reports to see if what we're seeing is similar to what they're seeing. It could also be, some of the surveys that come out like Birthis or the PRAMS data, and really applying that to our work as well. And then I think that looking at this external data is really important because it provides that additional context that we might not always, or that we definitely don't see when we're just looking at our health plan data. And the external data piece is, again, it's not the only thing that we need to look at with this data, which I'll talk about in a minute, but it's another factor that we need to consider in addition to the data that we're looking at internally. All right, so this is, I think, where I wanted to have the most discussion. I'm trying to also be mindful of the time. But I was trying to think about the question around the complexities of REL data and looking at it from a pragmatic perspective as well as an ethical perspective, because those are both really real, tangible areas to think about REL data and how we use it as a health plan. So a couple of things at the top is when our member data is reported to us, as I mentioned, like on the enrollment file, it's oftentimes a point in time snapshot of a member, just like with our health risk assessment, that's, one point in time. And we know that people's feelings about things can change, how they identify with something can change, their level of comfort in sharing data about themselves can change. And so we have to keep that in mind when we're reviewing our data internally, deciding what we ultimately do with that information, because we want to keep the member at the center of everything. Another piece that I thought was really important is, and this was brought up earlier in the presentation as well, is we use the OMB categories when we're reporting out our data to the state or to other spaces where we're welcome to share information. And that's really limiting when you have someone who's multiple races or doesn't identify with a particular category as it's listed there. So that, I think, is a pragmatic challenge, but it's also an ethical challenge for me in terms of how we share this information about our members, how we look at it, and trying to stay away from putting our members in a box when it comes to what we do with the data and how it guides decision making. The last two areas that I wanted to focus on are again more in the space of ethical complexities. And item 3 is how I think about it is data is step 1. We have access to all of this data about our members, about providers. We're pairing that with external data about communities, and it can be really easy to identify a disparity within a particular racial group or in a particular geographic area. And I think we try to be very intentional about saying, okay, we're noticing something in our data. We need to now engage the community or partners that are working there, or get support from a partner in some way to look at this from the lens of that member perspective and community perspective, to ensure that we're not reading too much into the data, or to give, or and more importantly, to give communities a seat at the table in what our next steps are. My experience has been that communities are never really surprised by the data that we see, and oftentimes they have thoughts around how we can best support their efforts, and we want to ensure that we're bringing that voice in, and that the actions that we take based on the data that we're collecting and the data that we're seeing internally are actions that are welcomed by communities and members and partners, wherever that is. And then that kind of leads to the fourth, or that does lead to the fourth item, which is the member perspective. We really try to keep that member and community voice at the center of the work that we do, and let that lead the action, like let that voice and perspective be what ultimately leads to action. So if our data is step one, the biggest step is really taking that data and sharing it with communities and identifying where we go from there, and how we work to be a good partner with communities and with our members to take action on these in these spaces where it makes sense in our role as a health plan.
Thanks, Jessica. I just have a quick question for you, and then we'll move on to our next speaker. You provided a great overview of the considerations that you and the organization you work for, Molina, takes to understand your population a little stronger and better. I'm curious if you have an example of that you could briefly talk about where you are working on this right now.
Yeah, so there are a couple of, there are a ton of areas where we're working on this. I think the ones that come to mind from the top are how we identify quality gaps or disparities within our quality data. So looking at HEDIS measures and stratifying those with this REL data. So looking at timeliness of prenatal care through the lens of race and ethnicity, and really looking at all of our HEDIS measures through that lens. So that's one example. And I think that gets to the last slide where I was talking about, you know, we may see a disparity within a particular population, within a specific geographic area. And that can sometimes lead us to be like, oh, well, I feel like I can find the solution to that, or I know what we could do to address this. And it can be really easy to just like see these disparities and be like, here's what we need to be doing. But where we're really trying to work right now is we're doing this work around stratifying our data, but how do we ensure that we're engaging communities around what are, I don't want to say solutions, but what are ways that we are welcome to work and address the disparities that we're finding? And how do we partner with communities to address those disparities rather than just work solely from the data that we have and try and like keep spinning our wheels internally to address something solely from an internal perspective? I hope that made sense.
Yeah, thank you. I really appreciate you adding that context. And we're looking forward to hearing more from you in a little bit. I'm going to go ahead and introduce our next speaker and welcome them to come forward. Dr. Matt Jaffy from the University of Washington. I'll pass it off to you.
Great, thanks. So I'm Matt Jaffy. I'm a family physician and a clinical associate professor in the UW Department of Family Medicine, as well as the associate medical director for UW Primary Care and Population Health. And I actually really appreciate being able to hear what people across our region are doing. And I think you'll see some similar themes in what I'm about to present. So just to give a little bit of background about UW Medicine Primary Care, we're a primary care network that serves the greater Puget Sound area. We have 15 community-based clinics, including 3 residency clinic sites, and then 10 hospital-based clinics. You can go to the next slide, please. And so I wanted to talk a little bit about our opportunities for REL data collection. We have 3 spots where we mainly get this information. We have a contact center that helps us with appointing, so a phone center. We have our clinic staff, which again are spread throughout all of our different sites. And then we're on Epic, which is our electronic health record, and the patient portal, MyChart, is another opportunity for us to collect that data. I pulled out our contact center has a robust policy and procedure on data collection, and I just wanted to pull out a little bit about what they do. They have several categories that they require for to be collected for every patient, and you can see those here. And then they also have a training that they have all of their staff go through, specifically on avoiding assumptions, some scripting for staff to use when gathering this information in recognition of the sensitivity, and then a standardized way to enter that data. Our clinic staff use some of these similar trainings as well, but our contact center has really pioneered some of that work. And then I'm going to give some specific information that I pulled from our MyChart patient portal that shows the areas where data can be entered by patients as well. So we'll go to the next slide, show that. So here you can see the specific categories that patients are able to select. So within race, you can see that there are 7 categories that are as I think you've seen in other slides, based on either US Census OMB categories. There also are 3 options for patients to select, including if they decline to answer, if we're unable to collect that information, if it's unavailable or unknown. And then and actually under race, patients can select multiple, which I'll show you a little bit in a dashboard that I want to present about some of the complexity that can develop because of that. And then under ethnicity, you can see that there's a single selection as well as options for patients to decline, or if staff's unable to collect that, or if it's unknown. In the ethnic background section of the data, we have a lot more detail that can be gathered. There's actually over 120 different options that are available, and patients can select multiple options. And similar amongst language, there's over 160 different options that are available, which does require in that category that patients have selected a single language that they're fluent in. And go to the next one. This is how we go about using data analysis. So we have a software company that we've contracted with called HBI Solutions, which other people may be familiar with as well, which aggregates data from our electronic health record as well as multiple other sources. And the way that this that the data is then filtered down is into 14 larger language groups that allows us to cluster patients into, but I'll show some of the potential barriers that can present when we get to some of the other slides around dashboard. And the same way in race ethnicity, there are 15 different categories. We can get down further into the data. We can actually access it in all of those other categories that I had shared in the previous slide, but it does take some additional steps to be able to analyze that information. Next slide, please. So I wanted to share a specific initiative that we've been working on now for the last couple of years as an example. So we have a breast cancer equity initiative that's a system-wide strategy to help UW-Medicine meet the goal of eliminating disparities in breast cancer. And it's specifically amongst women who identify as Black or African American. The objectives of this initiative were to produce a dashboard, which I'll share in a moment, to help with monitoring of those disparities, to work collaboratively with community representatives to identify what are the barriers that are specifically leading to disparities, and then to develop an analysis of the causes and to implement process improvement initiatives to help to address those disparities. Next slide, please. So as I was saying, here's a representation of that breast cancer screening dashboard that's been developed. And I wanted to highlight 2 of these boxes specifically. There's the performance box in the upper left corner, and you can see that there are paired columns. Those paired columns by color show patients who are Black or African, who identify as Black or African American, compared to patients who identify as white. And then the green dashed line on that shows where the goal is. And so this is a way for us to monitor on an ongoing basis how we're doing with comparison between those two groups. Each of the different colors represents a different entity within UW Medicine, and then there is one set that represents all of UW Medicine as well. So it gives you an idea of how you can compare and where you can target interventions, additional resources to help to narrow those disparities. The lower box is the performance box, and you can see there's a green line and there's a purple line, and those are displaying month-on-month disparities between our patients who are Black and identify as Black or African American and our patients who identify as white. And again, the idea is to narrow those disparities. And so drawing those lines together and then ensuring that they are both moving up that we're closing the gaps between the two, and that patients are getting breast cancer screening performed. You can go to the next slide. So this is another version of the dashboard, and this is showing the race, ethnicity, the larger groups. And the one thing that I wanted to point out on this slide is, and I think it's, again, it's been mentioned in other presentations as well, that there are categories within here, including patients who have declined to answer, patients who are multiple races, patients who have unknown race or ethnicity. And so there can definitely be patients who fall into those categories that are not being captured in the way that this data is being presented in perhaps the most obvious ways, and can make it more difficult for us to figure out who's being hidden behind this. It's actually another column that includes another race if patients don't land into the categories that are represented on this dashboard. The lower portion of it shows the trends over time. You can go ahead and move to the next slide. So I just wanted to run through quickly the process improvement interventions that have that we've done as part of this initiative. We have a role within our UW Medicine Primary Care network called a panel navigator that is really responsible for performing a lot of these population health activities. And they are the ones that are doing much of the work that's outlined below that. So targeted text and phone outreach, patient education, marketing, communication, events and health fairs. And then separately, there was a lot of effort that was put into scheduling improvements. There was inconsistency around getting patients scheduled, as well as deployment of resources. And so a lot of collaboration went on between groups and to try to help with getting patients the right access to breast cancer screening in the right places, the right times. You can go to the next slide. So finally, I just wanted to run through some of the lessons learned. And I think, again, these themes have come out in other people's presentations, but it really does require organizational investment and prioritization. As you can see, a lot of work has gone into trying to narrow the gaps between patients who are Black and African American and white in the cancer screening area. And obviously, there are a lot of other initiatives that need this kind of work as well. Partnerships with the community organizations has been vital and has really helped to inform the interventions and a lot of collaboration with the community. We have, I think, continued work to be done among with policy, procedure, and training consistency in data collection. And then the other thing I think that we've learned by working on breast cancer screening is that this analytics and process improvement work that you develop really needs to be broadly applicable to other health equity projects like diabetes, colon cancer screening, cervical cancer screening, and a variety of other areas. And then the other thing that I've pointed out in our dashboards is how the REL data categories can really hide diversity, and that it's critical to consider other factors, including language, ethnic background, social determinants of health, geography. Patients who are clustered into our patients who identify as Black or African American are broadly diverse, and that does not come out unless you really dive deeply into the data. I think that is my last slide.
Thanks, Matt. I have a question for you based off of what you were speaking on in a previous conversation you and I had during our planning portion. And you were highlighting how there's different audiences within these populations who, for one reason or another, may fall into unable to be identified, unknown, declined to answer, which is all a valid different responses, but how that may impact the data that we're seeing and the story that's being shared. So I'm just curious what you and your organization may be doing with that information to help inform or understand your data some more.
Yeah, and I think that falls back on the importance of training our staff and helping them to be able to talk with patients about this when we are collecting that information, and being able to demonstrate to them how it really helps us to be able to identify those patient populations that are being missed in this. I think that it's really been eye-opening as we've been going through this about how many of those patients are falling into those categories. And the other thing as well is that being able to allow patients to identify as multiple races, multiple ethnic backgrounds is really critical, but then being able to get into that level of detail when you're doing your data analysis, so you are not missing patients who may speak a different language than other patients who are kind of falling into that category. So you can make sure that you're partnering with the right communities and developing the right interventions to reach those patients.
Absolutely. Thank you so much for that answer. Now I will go ahead and invite your fellow speakers back to the Zoom screen, and also Sarah Halvik to begin our large group discussion. I'll stop sharing my screen too so we can see everyone.
Thanks, Emily, and hi all. I'm Sarah Halvik. I'm the Vice President of Data Solutions at Comagine Health. And just thank you, speakers, for fantastic presentations. You've packed a lot into a short period of time. So audience members, if you have any questions, please go ahead and type those in. But I'll kick it off with one, because there is a theme that I heard pretty consistently across all of your presentations, which was how to ensure that our data, including the collection, analysis, and reporting, so kind of along the entire continuum, helps to make visible populations that are overlooked or underreported. That is, as we are looking at collecting race, ethnicity, and language data, how do we ensure that the person is being seen authentically through the data that is being captured? So Jessica, you mentioned the importance of building trust with members to collect the most accurate data possible. Cade mentioned the importance and challenge of messaging to all of their members about this upcoming ask to report the information. So my question for all of you is, what communication or trust building modes have been most successful for you, and what does that look like in your efforts so far? Whoever wants to start.
I can go ahead and start. So, I think that one of the, certainly one of the things that we've leaned on within the UW Medicine primary care system has been our relationship with our patients. We have an inherent trust that we have by being their healthcare provider. And so being able to communicate with them about how important this information is, so that we can help to develop support and resources for the care that they need, I think has been something that's been maybe an invaluable kind of leg up that we have on being able to try to identify this information, the importance of this information when we're communicating that to patients. The other thing is also the partnerships that we've had with members of the community too. I think that being able to partner with people who are part of that patient population really helps us to be able to craft the interventions and the way that the resources are being deployed that speak to that individual group in a way that resonates better with them. And it can certainly be sometimes a hard sell on trust in the healthcare system, but I think that that partnership's really critical to being able to help patients to understand the importance of gathering this information.
I can go next. So trying to think the best way to approach this question. So I think from our perspective at Molina Healthcare, I really appreciate what the previous speaker said, we're in a little bit of a different situation in terms of building that trust with our members, right? Because we're a health plan, and I think if the healthcare system as a whole is hard to trust from someone, a health insurance company is really low on the list of who they're going to trust. So I think how we go about engaging our members and building that trust is really important to us. We try to be physically present in communities through our various different teams that are out there building those strong relationships. But I also think we try to nurture the relationships we have with those trusted voices who are partners in the community, right? So those are like our provider networks, the CBOs that we work with, the community partners that we work with, because we know that those are the people that our members trust. And we want to build strong relationships with them so that we can work with them to support our members. So it's not always us reaching out and engaging our members directly, although certain parts of our health plan definitely do that. Like our care managers and our health connectors and our community engagement folks build really beautiful relationships with the members that they work with. And so I think that's one example of how we utilize those teams and those individuals to bring that member perspective to the table when we're collecting data. But I think holistically, we really try to ensure that we're engaging those trusted voices and bringing the member perspective and the community perspective to our data collection, and then the action that we take based on the data through those partners.
Yeah, trust is always going to be an issue for us being the state and we're the employer. So of course, they think the mindset of our members is, well, they're doing this in an effort to try and figure out how they can reduce something, reduce some costs or aspects. I think the value proposition for them is going to be part of our key messaging that we want to provide. And what does it provide to them? What does it provide to their coworkers who they might not recognize, and try and help create a little bit of discomfort. I think the status quo crowd it has really kind of sunk in pretty hard and set their feet in, and some disruption is going to be important. And I think inherently the historical outreach to communities through our programs have not been great. We deal more on the stakeholder level, and so reaching down into the community level. I actually have a position that we're just hiring for, which doesn't even exist in our agency yet, which is a stakeholder and community engagement manager, someone whose job is just to help us get out there and reach our members. We had a really good lesson learned last year with regards to actions with retirees, and realizing we need to do better in engaging retirees directly, not just with the high level associations that represent large communities of them. And so bringing the right stakeholders to the group, but also finding opportunities and making purposeful outreach to the different communities that we have anecdotal reason to believe and larger generalities to believe the disparities that they are dealing with, but wanting to actually go and touch those communities so that we do see their stories directly, and that they know that we've heard that and we're just not seeing them as data sets for us.
That was great, thank you. And I just wanted to note too that unfortunately Dr. Rose James had to drop off the call early for another commitment, so we don't have her with us for this Q&A session. I had another question for you all. So following these great trust building efforts, at the end of the day, we do need to collect data on the populations that we're serving and building trust with. And a lot of times the race or ethnicity or language categories that we have to work with are limiting. And I think, Jessica, you mentioned the limitations of the OMB categories. I know Dr. James talked about the trouble with the multi-race category or the other category. So I'm wondering, for each of you, how have you been able to work within these limiting race categories and still make progress toward identifying the patients and identifying some of those drivers of health inequity?
I'm gonna chime in first on that one, mostly because we're not there yet, but there is certainly a recognition of what Dr. Jaffy was saying and Ms. Beach, that different levels of striation can provide certain views of a population, and where if in the ethnicity or race, there's only 7 categories. I'm sure there's, not to mention multi-ethnic, multicultural, multi-racial identifying individuals. It's going to be something we're conscientious. So that's why we're getting an opportunity to learn from a lot of where other people have already started on, and seeing what we can also do to push things in a direction that can also help spearhead it for others as well, as an employer, that is.
I can add to that as well. So I think for us at Molina, we're definitely on the journey. Like, we recognize that it's limiting and that there are constraints, and that it's challenging to work from the broad categories that currently exist. I feel like we're taking 2 paths around this. So one is like, what do we do right now? How do we work within the space right now and ensure that we are trying to think about who our members are and what that looks like, and what does that multiracial category actually mean? How do we engage with those communities? What do we do with that data in an intentional way, in a responsive way? So that's kind of like the now, like, how do we move through that work now? And then on the other side of it, it's how do we move forward to make this more comprehensive, I guess. And I think that's really like, that's a tech solution. It's an IT piece. And like, what are the systems that we're using internally? How are they taking in the information that we get from the state? And how are we ensuring that it's translating? I'm not an IT person, but translating in a way that gives a more holistic picture of who our members are, instead of, just applying. I know that there are like algorithms that get applied when we internalize that data to put it all into like a nice, Excel sheet or dashboard, or however it looks when we ultimately look at it, but wanting to think through, how do we solution for what we lose in that process, from when we're getting the data to when we actually look at it and use it to try and identify disparities or other things. So those are the 2 kind of frames that I look at it from.
I can talk a little bit more about the breast cancer equity initiative, because I think that example is really helpful to see what you kind of discover when you're starting to apply this to improving a particular disparity. So when we initially looked at patients who were identifying as Black or African American, and trying to partner with the community, with community representatives to figure out, what interventions might be helpful, I think there was pretty quick recognition that, again, like I'd said during my presentation, that is a diverse community in itself. And having the ability to then dive down into the data to see, what languages does that community speak? What ethnic backgrounds do they identify with? And then once we'd identified that there were sort of larger groups amongst that big sort of category, we were then able to reach out to members of those communities to try to figure out what interventions would be the most helpful for them. Would it be helpful for us to be present at a health fair? Would it be helpful for us to participate in a faith-based organization that was really big with that community? Do we need to translate our patient education materials to different languages to be able to reach different communities amongst that larger group of patients who identify as Black and African American? Being able to have access to really kind of pull that level of information out was really critical for us to reach those sort of hidden communities that are buried within that larger category. And I think that having, at least for us, patient representatives, we have a patient advisory council that we can partner with, some other areas that again, we're not coming up with internal solutions. We're going to people who are out in the community to try to help us identify what would make sense to them, what makes sense to their community. That was really a critical way to do that. And we're applying that logic to other projects that we're now working on. So like I had mentioned, diabetes, colon cancer screening, and actually bringing together a larger group to kind of come up with, what is our sort of overall strategy.
Oh, that's great. Thank you. And maybe just one build upon that, going back up to a question that Michael Garrett asked in chat a while ago, is if any of you have thoughts about how healthcare organizations will incorporate the anticipated changes to racial and ethnic categories per the recent White House executive order. And there's a link to it in the question there, but wondering if any of you have thoughts about that.
Yeah, I've reviewed those new requirements. I think they're helpful as a good starting point for us. I think because we as an employer don't have the same requirements for collection of race, ethnicity, language data. In fact, we don't have any requirements for the collection of it. We have a little bit more of a open opportunity for us to take on that, rebuild, build on it, knowing what our population is and being able to drill into certain areas we'd like more. We also have another component that kind of is maybe outside of what health plans would be looking at or providers. We also are going to be able to collect economic data on our members because we also have their salary information. So we're going to be incorporating that and trying to figure out, what that's going to look like, building on it and trying to think as much out of the box from a starting point with what the White House, the new requirements are, and seeing where those land eventually in the next couple of months. But I think we see it as a starting point, not the end point for us.
And I'll chime in here as well. So from the health plan perspective, I think the second piece of my last answer is what kind of still holds true here. It's that IT building from the operational perspective. And then I think the partnership with HCA and other health plans around what that ultimately looks like for us from a reporting perspective, how we incorporate that information, because they guide our work there as well. So I think those are the two kind of spaces where we will be taking action around that.
Great, thank you. Another question. Let's see here, Dr. Jaffy, you had on your last slide there about how the REL data categories often hide diversity and the importance of considering other approaches, including social determinants of health, geography, other factors to be collecting. So I'm wondering for all of you, what other data are you collecting in combination with race, ethnicity, and language? And how is that helping your data-driven decision-making efforts, specifically around reducing disparities?
I'll start with just an example, which we have not done as of yet, but there's a lot of discussion right now going on about how we can start to do a better job of collecting social determinants of health. There's again, within our sort of billing coding, we can identify the variety of different barriers that patients are experiencing, whether it's homelessness. I guess I could add that, we do have some of that starting as far as like lack of housing, things like that. But I think that's a big area for us to that we're going to be getting into. And I don't know yet how exactly we're going to kind of cross-reference that information, but like I said, we certainly have started discussions around it, and again, with the work that we've been doing, it's become, really clear that there are a lot of other factors that are outside of REL data that you need to incorporate if you're really going to make significant changes in reducing disparities. So social determinants of health is one area that I think there's a lot of focus on for us right now.
And as the employer, I had mentioned that we're able to collect, and we will be collecting financial information, income information. Part of our efforts are also looking at any disparities within the employment practices themselves. So looking at particular job classifications, job categories, expanding that, the equity view far beyond just the health equity component, which is our primary purview that we want to look at it through, but the opportunity to provide this information for our authorizing environment, for the legislature and for the governor's office to be able to establish additional policies. We see this as a really unique opportunity to start collecting and drawing these connections, to which health is probably one of the foundational pillars of a holistic approach to addressing inequities in our communities.
And I'll add, I think social determinants of health is another area where we're really trying to apply an additional lens around this. I think, and I said this in my presentation, the REL data is like one component of how we look at health equity, in my role, but then also just holistically across our health plan, how we look at our data to drive decision making. And so I think that we're trying to really be intentional about what are some approaches that we can take that bring in SDOH data. How can we work with our providers to increase the access that we have to that data? How do we, I talked about our internal data collection, right? Like the health risk assessments that we do, the other outreaches where we directly engage members. How can we leverage those connections to our members to build that trust, but also think about what are things that we don't currently collect or we're not really able to bring in to the data that we're looking at, and is there a way to start incorporating some of those questions or that information in there in a thoughtful and intentional way? Because I think anytime when we're directly engaging a member around questions, where we're asking questions and requesting personal information, we want to do it in a way that does not unintentionally cause harm, where folks are feeling comfortable with sharing that data. And so I think that's a big conversation for us at Molina is what are we doing now with these areas, and then how can we be enhancing that through a lens of health equity and extending that across our overall health plan and the work that we do.
Yeah, it makes sense. And we've got just a minute, so maybe in that last minute I want to expand on that a little bit. So I mean, collecting data on all of the important elements is one piece of it, but then how do you look at those data in combination with the race, ethnicity, and language data that you have? So I'm wondering if you could each say a little bit about the way that you approach the analysis and reporting of multiple demographic pieces of information together.
For us, how we approach that is identifying the what's, like what is it that we're trying to look at, and is that a particular, like I talked about HEDIS measures in the presentation, but it could be a particular population within Medicaid. It could be, I won't say like a specific diagnosis, but maybe a particular type of care that's being accessed, like really defining what it is we're trying to find out. And then identifying how we best layer that information like into the reports that we're creating internally. I always try to add a geographic component to that because I think, it's really easy to be able to say we have a disparity within this population across the state, but it's oftentimes not across the whole state. It's usually in a specific area or in pockets of areas. So really applying that geographic lens to everything that we do, we try to be intentional about that. And then as, I and the other presenters have said the whole time or throughout this entire presentation is looking at the data, but figuring out how we actually make meaning out of it and bring that community voice into it. Because we, like with all of the indicators that you've identified, we can layer those things. Like we can layer it all on top of each other until we're really just looking at like a group of 10 people. And it's not really meaningful there. So how do we have to set parameters for ourselves and look at what our final output is in terms of a report or the data that we're looking at and identify how we best use this. What's our next step? How do we take this now and then start to engage communities and partners around it? So yeah, thanks.
That was great, thanks. And I think, Emily, sending it back to you. Thank you, presenters.
Yeah, thank you, everyone. As we were wrapping up, we wanted to quickly let everyone know of a couple more upcoming events at the Foundation for Healthcare Quality. On June 14th from 9 a.m. to 12 p.m. Pacific time, we are hosting a social need and health equity summit that is open to the public, and there is a link. We'll put it in the chat and also email it out shortly, where people can sign up and join to attend that. Additionally, our BRE Collaborative is seeking new topics for our BRE reports for 2024. If you're interested in providing a possible topic for us to look at, there's a link also in the chat that you can submit that suggestion for us to review. We now want to conclude this webinar and thank everyone for participating and joining us, and also a huge thank you to each of our speakers for providing us with their time and knowledge and expertise today. There will be, after this webinar, the recording will be emailed out to individuals who signed up, and we'll plan to send out the PowerPoint slides as well. If you did not sign up, we will post the recording online so you can access it there as well. Thank you, everybody, for attending today, and we hope you have a great rest of your day. Thank you, everyone.